So good afternoon, everybody. Welcome to the latest in the ECIST Keynote speaker series. Today we welcome Dr Gordon Caldwell to the stage. Looking forward to this one. I think it's going to be really interesting. No pressure, Gordon, but I think this one's going to be really interesting. We are recording, folks, so just so you know, so you can share that afterwards as well if you want to pass this on to your colleagues. Will make it available on our YouTube channel, and we'll send the link out and also put it on our future NHS platform. So we've got Gordon for about half an hour talking to us, and then there'll be a chance to ask him questions afterwards if you want to. So post comments or questions in the chat, and I'll pick those up and ask those to Gordon afterwards. Or if you just want to ask Gordon some questions later on, we've got plenty of time for that built in. So should be a really great opportunity to dig into some of Gordon's experience. So just a bit of background for those who don't know Gordon. Not many of us don't know Gordon. He's been around for some time, very prominent radical thinker in terms of delivering healthcare. So Gordon's currently a consultant physician and clinical lead at Lawn and Islands District General Hospital in Oban, as part of NHS Highlands in Scotland. Gordon previously worked at Worthing Hospital, which is part of Western Sussex Hospitals, now of course University Hospitals Sussex. So those of you who know Gordon, we all know Gordon for his innovative approaches to healthcare, in particular very much around the patient experience, such things as the Wardrones stool and the double screen in outpatient clinics are a couple that really stand out. And this is just about how we look at patient care from the patient's perspective and wonder what it's like for the patients who either sit in the chair or in the bed. And that's one of the things that I've always been really impressed with Gordon's approach. Also his keenness around lean thinking, which, you know, by just literally taking waste out the processes. So having said that, I'm going to hand over because I'm sure Gordon's got plenty to share with us. So Gordon, over to you.
Thanks, Nick. I'm going to be talking with you for about half an hour, I think, about the ordinary importance of Wardrones. I'm sorry I can't see you all, and it makes it a little bit difficult when I'm talking, not being able to see the audience and see the feedback and see whether you're paying attention or drifting off to sleep or getting bored or whatever. Yes, I've been a consultant since 1993. I trained in medicine up to 1980 when I qualified at King's. And I think I've always been interested in Wardrones, as what's going on in them, how they're run, what's happening. And I called the talk the ordinary importance of Wardrones because what's ordinary, we tend not to notice. It's ordinary for a sprinter in 100 meters in the Olympics to get down 100 meters in 10 seconds, and he doesn't really notice it because it's ordinary, whereas we'd think it's something amazing. And there's dangers in the ordinary, which we'll come round to during this talk. But where I want to start is with a story. So about 8 years ago, I was doing an admitting ward round early in the morning on the acute medical unit in Worthing Hospital. And we were attending a man who was in his late 50s. I think he was a school teacher. He's married with 3 children. And he was clearly dying of pancreatic cancer. And on the ward round that day, obviously I had my team of doctors, including the doctor who had admitted the patient. But there was a new student nurse on the unit who I hadn't met before, and she was attending the patient with the ward sister. So I asked the student nurse for some background on the patient, and although she'd only been working on the ward that day and only working for a couple of hours by that stage, she had a very good understanding of who the patient was, his circumstances, his knowledge of the severity of his disease, and that his pain, which had been severe overnight, had been well controlled with the morphine infusion. So I was very impressed with this student nurse who knew all this information. And then when we consulted with the patient, he'd had pancreatic cancer for maybe a year. He had been diagnosed through the standard medical way of investigation, history, examination, and lots of tests, endoscopic ultrasound, CTs, MRIs. He'd had radiotherapy, chemotherapy, episodes of sepsis and such like. But I think he now understood that he was dying of pancreatic cancer. And as I consulted with him, I was feeling rather helpless as to what we could do to help this man. And so at the end of our consultations, I always say to the patients, is there something you want to ask or something we can do for you or something that we can do to help? And this man said that what he'd most like would be an ice cream. well, this was about 10 o'clock in the morning, I think, at this stage, and didn't know what was on the menu for lunch. But later on in the day, I heard that the student nurse had gone away during her break, and after her break had gone to the hospital shop and bought this man a Magnum White. And she took it back to him, and he'd just eaten his lunch. He ate the Magnum White, and then he died. Now, I'm telling that story because the practice of medicine is human relationships. All of us who work in clinical care, we have the privilege sometimes of seeing new life starting at birth and then people dying at the end of life. And medicine is fantastically scientific these days, and it's very complex, and we have modern and difficult treatments, different treatments available now. But we must remember this is within the context of human relationships, and that it's the human touch which is essential, I think, to our practice of medicine. And if at the end of this session today you go away with one idea, I hope it will be that you establish some personal connection with each of your patients, which you can remember your patients by, so that the practice of medicine or nursing, whichever you're involved in, is human again. I liken this a bit to, humans need nutrition, but actually what we eat is food. And the difference between nutrition and food is the spice and the flavorings and the textures. And in medicine, if we forget that the human relationship is the spice and the flavors and the textures of care, then our work becomes very bland and mundane and uninteresting. And I think crucial to the central practice of medicine is that remembering that it's a human relationship. And in this slide, I don't know if you can see my mouse, what I particularly like about this, obviously this isn't the patient who is dying of pancreatic cancer, is whether this is the nurse or the doctor sitting at the same level as the patient, eye to eye, and in a human ordinary conversation. Now, in medicine, the smallest oversights can undo the greatest acts. So one of the things that got me interested in the question of quality and safety on Wardrones was probably about 15 or 16 years ago now, when there was a gentleman who had been admitted under my care. He was in his 70s. He had been an engineer all his life and a smoker all his life, and had chronic obstructive pulmonary disease. And this was complicated by an episode of pneumonia, which required intravenous antibiotics to resolve his pneumonia. And the day of this particular ward round, I was intending to send him home when he said, "Yes, but what's this thing on my arm, doctor?" And we didn't take a picture at that time, but in the middle of this was the day before was a cannula. And the cannula had been left in for 3 days longer than was needed for the intravenous antibiotics. And this area here in the middle is MRSA, and he had MRSA septicemia. So he required an extra 2 weeks in hospital for treatment for MRSA septicemia, which we had given him because we'd failed to take the cannula out after we had successfully treated his pneumonia. Now, you might say that's not too bad, although I'm sure the patient didn't like an extra 2 weeks in hospital. But imagine if you work in a cardiothoracic unit and you'd put in an aortic valve replacement, a huge effort, and then forgotten to take a line out, and that line got infected. So in medicine, we can do tremendous work these days on behalf of our patients, but we need to pay attention to these really seemingly small aspects of care so we can keep patients safe. And it was around that time that I think I started to think, well, couldn't we have a standard process that we go through at the bedside with every patient to make sure that we don't miss things out that later on turn out to be very important? So I'm going to then move on to talk a bit about ward rounds, obviously, but I think that always has to be set in the context of the work of a hospital. In my mind, we often don't state these very obvious things. The work of a hospital is to keep mothers and babies safe in childbirth, cure the curable. We expect people with appendicitis to have their appendix removed and to recover, people with pneumonia to have antibiotics and get better. We want to promote and maintain patients' independence as long as possible in long-term conditions, and a lot of inpatient care these days is dealing with long-term conditions and their complications and trying to maintain independence for the patients as much as possible. We should also be predicting end of life and ensure that there's a calm end of life for those who are inevitably dying. I think vital part of our work is to train the next generation of healthcare workers to outperform this generation. And we want to do all that with a contented, fulfilled workforce. So that's clearly to me what the job of a hospital is. And right now, and Oban was just talking to Nick about the pressures we're under, we're having to decide whether to put our resources primarily into ward work and acute admissions and sacrifice some outpatient work at the moment. But I think in a hospital, we expect that the inpatient work and the acute work would be slightly higher priority than the outpatient work, both very important. Another thing that I think we're very poor at explaining as doctors and nurses to people outside medicine and even to each other is what the process is of dealing with a person with an acute unscheduled admission. It's very unusual for the person to come into hospital with a clear diagnosis. And at the most, what the admitting nurses and doctors will come up with is something called a working diagnosis. This is roughly what we think might be going on. And as time goes by, we refine that until we get closer to a final diagnosis. So this is what I call the clinical care cycle. Generally, when somebody arrives in A&E, we hopefully know something about their comorbidities. They've got type 2 diabetes and maybe prostate cancer and COPD. And what we're hoping to work towards is a diagnosis. So we take the diagnoses and comorbidities, and from that we come up with a treatment plan. And the treatment plans these days, because patients have so many comorbidities, can be quite complicated. We would take a simple example, a young type 1 diabetic with asthma. If we come in and they've got a severe asthma attack and treat the asthma attack, their blood glucose will inevitably go up. So we need a plan both for the asthma and for the diabetes, and that's quite simple, treatment plans. And once we have a treatment plan, obviously we have to implement the treatment. We have to make sure that the patient gets the intended treatment. And then there's monitoring of progress. And the monitoring of progress can vary from very simple things like weighing a patient with cardiac failure, right through to very complex invasive continuous arterial blood gas monitoring for somebody on an intensive care unit. But we need to monitor the progress and then see whether the patient's got to where we expect them to have got to, see if anything unexpected has happened, see if our diagnoses are correct or incorrect, and then go round the cycle again. And this is really where Wardrones fit in, is the review of progress. So if a patient's been seen in accident and emergency, transferred to the acute medical unit, we're hopefully at this sort of stage, the next morning they have a morning ward round and it's the review of the progress against anticipated trajectory. And people will go round this any number of times, and to the three outcomes we know, their health has got better than when they came in, they've reached a new stable but an impaired level, maybe they came in with a stroke and now after a couple of weeks they're able to walk again, but that's the stable condition they're in, or the patients die. And I think it's helpful to think of this and to see that this is where Wardrones fit in. And within the project that ECIST are running at the moment, there's a lot of discussion, should we call them Wardrones? Well, it's common parlance for what doctors do on a regular basis with patients, and it could just be called scheduled review of progress if you wanted to get away from the Wardrone terminology. All of you who are ECIST professionals will see that that is a plan, do, study, act cycle. And it's interesting that doctors do plan, do, study, act cycles all the time without realizing, but as soon as you ask them to do a plan, do, study, act on the flow of patients from A&E to the acute medical unit, they fall apart and think it's something they can't do. Whereas we're doing it all the time and working with great uncertainty in this area. So Sidney Dekker is a world expert in travel safety, and he's also moved now into healthcare safety. And it was reading one of his books called Drift into Failure, where he talks about how easy it is to ignore what seems ordinary. And he's said words to the effect that the greatest danger to an organization dealing with complex matters is what it accepts as ordinary. So, for example, in this hospital in Oban, we don't have electronic prescribing, so we accept it as ordinary that between the patient being sent to our hospital as an acute admission and going home, their medication list may be rewritten by hand 12 times by 4 different professionals, all creating new errors. And very soon after an FY1 doctor or a nurse comes into their career in the NHS and hospital, that's just accepted as ordinary. That's the way it is. So the immediate reaction when they first saw it, this is terribly dangerous and flaky, goes away because that's just ordinary. And certainly when I started off this work on Wardrones, the NHS considered Wardrones as so ordinary it paid no attention to them. If we wanted to know how many outpatient attendances there were yesterday across the NHS and how many did not attend there were, I suspect that somebody could produce that statistic for us. They could tell us the statistics for accident and emergency targets. But I don't think the NHS could come anywhere near counting how many Wardrones there were, how many patients have been seen, how many patients weren't seen, how long it took, how much expenditure there was in it. So the NHS, certainly around when this started in 2004 or so, was paying no attention to Wardrones. No standards, no measurements, no audits, no targets, no costings. Therefore, you could conclude that the NHS doesn't think Wardrones matter. I would argue that's actually not the case, because we know as soon as the hospital's full, when you're up against a crisis, the one thing the chief executive and medical director always insist on is everybody goes and does a Wardrone, because they realize it's actually an important event where decisions are made. So over the years, I've come to the conclusion that I think Wardrones are the most complex human activity there is, but they're regarded as so ordinary by doctors and nurses that we don't realize how complex they are and how dangerous they can be. So we tend, people say it's not rocket science, as if rocket science is something very complex. William Shatner was sent off into space last week. I'm doing a little survey on Twitter at the moment. So far, 95% of people think that William Shatner was safer in space than if he had been admitted to an acute ward, because the space industry pays so much attention to safety, so much attention to detail, has standard processes, and is obsessive about making sure that everything stays safe. So what are these things that make our Wardrones so complex? As I said, talking about the man with the pancreatic cancer, there's medical science, which has raced ahead in my 40 years as a career in the NHS. There's all the investigations, the complex investigations down to polymerase chain reactions and things like this happening for very short notice and very quickly. There's the whole question of what the diagnoses are, the treatments are, the ways of monitoring the patients. We've got stacks of nice guidelines we're all meant to be following, and specialist society guidelines. There's unexpected events. The patient came in with appendicitis, but on day 5 they suddenly have a pulmonary embolism. The whole thing is knocked off course very unpredictably. Of course, there's emotions involved. Our emotions, the patient's emotions, staff emotions, computerization, which has again come in a big way over my career, and I don't think we've actually managed to do particularly well. We've got guidelines on how we're meant to discuss DNA CPR, adults with incapacity, treatment escalation plans. There's the ethics of medicine, there's law, rulings by the High Court have had a big influence on how we discuss DNA CPR, religion, team working. We've got the targets and performance penalties if we don't do things properly, emphasis on quality and safety, documentation, bureaucracy, and I put vested interests at the bottom there. I trained in diabetes, so of course I used to think diabetes is the most important thing possible that a patient could have, and every patient has to be considered for diabetes, and if they come in with diabetes have to have big guidelines, and why didn't everybody follow them? Well, we've got so many vested interests, whether it's diabetes, pressure area care, falls, pain relief, everybody thinking that their particular thing is the most important. Dementia means that the frontline staff are now deluged with this bureaucracy and meant to keep up with it all. So you're doing this very complex activity at high speed in often a very poor environment. So that's why I say it's the most complex human activity that there is, but we all think of it as just very ordinary. Oh, there's another Wardrone going on. Now, I hate PowerPoint slides which have got lots of words in them, but I've found that this one helps people at least to understand what goes on inside my head when I'm doing a Wardrone. So think of your own wards where you work and the sort of noise and the interruptions that are going on your ward. And imagine we prepared for a Wardrone review of a lady who seems to have pneumonia, and diabetes and with high glucose levels. So if I'm the consultant, this is the sort of stuff that goes on in my head when I consult with the patient. Wow, she looks very thin and has clubbed, tar-stained fingers. I wonder if she's got lung cancer as well. Have I introduced myself clearly and got a good rapport going? This could turn into a tricky consultation. Oh, she's mentioned a headache. Maybe she has metastases to the brain or temporal arteritis. Have we measured the ESR? And did we even look at the chest x-ray? Now she says she hasn't been outdoors for 6 months, so she could be vitamin D deficient. Will we measure the vitamin D level or just prescribe some? Maybe she's already on vitamin D. She was on a long list of meds. Why is the student looking bored? I'll ask him to look at the meds list, and the F2 can look for an ESR result. Now, should I go on to the high glucose problem or the pneumonia next? Oh, her husband's arrived and he looks angry. Where's the nurse gone to? I need her to hear the whole conversation so she can calm the patient and her husband down after I leave, if this turns difficult. Oh, I must remember the medical director said we're doing poorly on VTE and dementia forms and looking for pressure risks, and the 4-hour target is going badly. Could I discharge this lady and do all her investigations as an outpatient? And damn, there goes Henry the Hoover, and the F2 has left to answer her bleep, and PAX has gone down, so we can't review the chest x-ray. Now, how many years has she smoked for? Now, when I've described that to other doctors, they relate very much. This is the sort of stuff that's going on inside our heads, even though we might look calm from the outside. And that doesn't leave any residual thinking capacity for, could her weight loss be from an overactive thyroid or badly developing false teeth or depression or just drinking alcohol, eating no food. So when you're on the ward rounds, doctors and nurses on the ward round may look, and say in Scotland, glaik it, and as if nothing's going on. This is the sort of stuff that's going on in our head and how complex it is, and how you have to be thinking on your feet and have access immediately to information to help you to make decisions. Right, so going right back to where I started really on my specific interest in ward rounds. I've been a consultant for about 10 years at this stage, and I felt there was something going wrong with ward rounds. And we had an acute medical admitting ward in Worthing Hospital, which was meant to look something like this. I think, you know, maybe the doctor and the nurse consulting about the patient. You can see who the patients, one of them's up walking around. There's a nurse here, maybe doing some observations. And this whole appearance here to me is of calm and quiet and control, and it looks rather nice. But generally on my post-take ward rounds, after acute admitting ward rounds, there was no nurse. So I can take that nurse away. The phones were ringing. The Hoover was going, the television was on, somebody was bringing around the drinks. I was trying to solve these difficult problems without much access to the facts, as Peter Sellers would say, shot in the dark. It's the facts we need, and the bleeps are going off all the time. I can remember specifically one ward round I was doing where I was consulting with a man who was in his early 60s, and I was concerned whether he might have an aortic dissection. So I had to listen to see if there was an aortic regurgitant murmur, which is quite difficult to hear. And we had the curtains round, and as I bent forward to listen to his heart, I hit my head on the television screen that was over his bed. And then I went to listen to his heart, and his bedside phone rang, and he started speaking to somebody on the phone. And at the same time, the cleaner came with the burnisher for the floor, pushed it underneath the curtains, and started burnishing my shoes. So when I presented this as an audit to our chief executive, to his credit, he changed the cleaning schedules to the afternoon, and he took all the televisions and the phones away, and certainly made sure that it didn't work until midday. So the next week, the ward was much calmer and much quieter. So if you're working on the management side, there's a whole lot you can do that can help me help your doctors and nurses when they've got all that going on inside their head, at least to have a quiet environment in it to work in. But he also said an interesting thing. He said that from what you've said, Dr. Caldwell, about the various admitting ward rounds on your acute medical unit, you have no common process between the consultants. One person will come and do it one way, one person will come and do it another. And at that stage, I didn't know what a process was. But he was absolutely right. There was very little standard process. So nobody really knew what was going to happen the next day on the ward round because it depended which consultant turned up. Now, also at this time, I was interested in training doctors, and there's a modernizing medical careers came along, which seemed to do a whole lot of thinking that you could train people in simulated environments, whereas I was really interested in training my doctors in the real environment of the ward round. I wanted to train them to be able to do ward rounds and to look after patients and deal with the unexpected and not some scripted event that was put to them in a controlled environment that often didn't look like a ward round. I mean, having said that, I think Natalie's talking tomorrow and she's done fabulous work on simulation. So there is a role for it. So I used to get my registrars to lead the ward round on the basis that I could then observe them, watch them and give them some feedback on how they ran the ward round. But the registrars enjoyed it so much that the senior house officers wanted to do it. And then eventually FY1 wanted to lead the ward round, and we called these reverse role rounds. And this is Claire, who since, as you can see, started raising a family. April 2009, she led the whole ward round of 26 patients with support from me and the registrar and the senior house officers. And we asked her, this was on a Monday, what was it like? And she said, I felt supported, but I didn't know if I did it all. And we said, well, that's interesting. I don't think anybody has ever asked what doing it all is on a ward round. So why don't you come back on Wednesday with your list of things that you think is doing it all, and we'll see if we can come up with some idea of what we're going to do for every patient when we do our next ward round on Friday. So what is doing it all on ward rounds? You can go away and think in your own context what it might be. But for example, one Sunday in May 2015, I did a ward round of 18 cases. I had amongst those 18 cases, there were 158 diagnoses and comorbidities quoted in their summaries. So that's highly complex already. 13 of the 18 patients were clinically frail. So if you're going to go and review these patients, could you remember 158 diagnoses and comorbidities? And could you remember to deal with each of them? And more important in the NHS, can you deal with all the things that aren't there that should be there? So I was surprised when I moved up to NHS Scotland to find out that I'm not allowed to access the NHS England summary care record. And in England, you're not allowed to access the emergency care summary from Scotland. So if I have a patient who's come from London a week after having some chemotherapy and is delirious with sepsis in our accident and emergency department, I cannot even know what cancer that patient had, let alone what chemotherapy and what comorbidities. So whatever it is doing it all on the ward rounds, we need a lot of information, and we need to be able to view a lot of information and make a lot of decisions and actions very quickly. Now, at this stage, Atul Gawande was beginning to introduce the World Health Organization Operating Theatre Checklist. So what we were heading towards was a checklist for making sure we'd done all the things that we thought we ought to have done. So we contacted him and asked for his advice, which he'd sent about 4 lines back, which could be summarized as never introduce a change that slows the overall pace of clinical care. And this struck home to me that we might have a ward round of 26 patients, a cohort of 26 patients, and that might usually take 4 hours. Now, if we introduce a change and it makes it 6 hours, that's a disaster. So when our electronic prescribing went live in Worthing, our ward round took 50% longer than usual because they hadn't predicted how the doctors would handle the prescribing and the reviews of medicines on the computers, which they hadn't given the doctors to use to review it on. So if we're going to do something, we couldn't slow the overall pace of clinical care. Sometimes you can do things sometimes that slow a bit of it, but overall speed it all up. So I mean, I'm very keen on typing in diagnoses and comorbidities early in an admission. Then I should never need to retype them again. So that takes a little bit longer at the beginning, but saves time down the line. And most of I'm very unaware of changes being introduced on the front line in the NHS on our wards, where people measure what effect it has on how much time it takes, particularly if it's something new in a complex situation, like when the electronic prescribing was introduced. They hadn't given us laptops as doctors, so every time we wanted to look at the meds list, we had to go back to the base station to get the computer switched on to look at the meds list. So that caused major slowing and could easily have been predicted by a little pilot study in the workplace. So if you think of all the nursing bureaucracy, which I'm sure you've seen me going on about on Twitter, most of that has been introduced without any time and motion studies at all. So I never had a big team of people to work with me. We went for very simple measurements on Wardrones. Start time, and I include pre-round briefing question mark, only if you're comparing statistics one department to another. They better describe what they mean by the ward round. Do they mean right from the time when you first start talking about the patients, or they mean the time you first go to the patient's bedside? The end time, does that include an after round debrief? I just counted the time from sitting down, starting to talk about the patients till we walked away from the last bedside, and I didn't include debrief at the end. Total number of cases seen, number of new and reviews, team members participating, especially nurse at the bedside. What we definitely know from Michael West's work is that hospitals which have strong team working get better outcomes for their patients and better experiences for their patients. And I think counting whether the nurse is present at the bedside is a very strong indicator of team working. And then I used to just account any unexpected events. So a checklist is of no value without a standard process. This well-being isn't a tick box exercise. What we're trying to do is review the patient's progress and keep the patient safe and have a process. Just having a tick box thing that we go through and tick it all off and say, yes, we've done it, is of no value if we haven't done it. So you may be waiting for a checklist. This was something similar to the first checklist that we ever did. We called it a considerative checklist for complete patient review. That meant all the things you had to consider. It didn't tell you whether you had to prescribe VTE prophylaxis or not. It said you had to have thought about it. And this was a sheet of paper that we printed off, and we'd usually give it to a medical student, or this time it was a medical student. And the medical student would tick off when we'd done things. And I see nurse present, no, 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 no. So what we're looking at was a preparatory discussion, checking the bloods and the X-ray and the ECG. Have we completed the VTE prophylaxis form? Was the patient clinically frail? Did we look at the vital signs? And what was the news score? During the consultation, was there a nurse there? Did we follow hand hygiene? Did we introduce ourselves? Did we look at a wristband for the patient? It took me 3 years to find out that a patient of mine had anaphylaxis to an antibiotic they're known to be allergic to, because some of our nurses had stopped checking wristbands before they gave antibiotics intravenously. Did we do a focused examination, look at the drug chart, if they're diabetic, the glucose, fluid balance? Did we agree what tests they could have done rather than the doctors just writing the bloods every day? Had we documented how long we thought the patient would stay in hospital? And then this active 7-point safety check. And I think we probably introduced this because the nurse was absent so often at the bedside. So we couldn't find out whether the patient was in pain or discomfort, eating or drinking, constipated, diarrhea, urine infection, cannulas and lines, pressure areas, DVT prophylaxis. So we actively asked the patient these. And of course, if the nurse is there, like they are in Oban Hospital, the nurse is always there, they know they're going to get asked these questions and they can sum it up in 5 seconds. If they're not there, it can take me 5 minutes to find that information in the notes. Did we sign the notes by the consultant, sum up, report plan to the patient? That's changed, I don't know, 300 times in the years I've been doing it, and looks quite different now. Again, if you're going to go in for this sort of thing, a functional team is essential. You have to have somebody in the team who's watching, checking, and is going to tell you when you've missed something. I can remember that, have I signed the notes? We put that in one time, and the medical student, after about 5 patients, said, I don't think you checked whether I'd signed the notes, did you? So I was going to tell you at the end of the round, Dr. Caldwell. So I'd have had to go back and find all the notes and sign them. So you need somebody who's going to speak up. So this is something I did to help form my team. Often on admitting ward rounds, I was working with doctors I'd never met before, didn't know who they were, anything about their background. So I used to say, this is what we're doing. We're going to try and get right diagnosis, right treatment, right time, right place, right pace, right to no harm, better next time. And that the participants physically signed in that they were going to take part in the ward round like this, and they were going to speak up. I think that made quite a big difference, that they knew that they're expected to speak up and what they're going to do. So form a team carefully, flatten the hierarchy, prepare your team for the work. One of the questions here was what to do in an emergency arises during the round. The SPR will go, and the number of times there was a cardiac arrest and the SPR just left and we all carried on with the work just because we'd anticipated it was good. That has changed over the years. So now my checklist, I'd stopped working on the wards in July, but I was back on the wards last month. I cannot do my work unless I've got something like this that summarizes to me what's going on with the patient, who the patient is, how old they are, when they're admitted, who the GP is, something about them, who they were or are, their clinical problems, the background diagnoses, progress notes, plans, and then the checklist all down here. Are they on an antibiotic? Are they on VT prophylaxis, oxygen, diabetic, delirium, dementia, pain? So different headings now from the previous one, but that's all right. These are the ones we feel currently are important. So this now is part of the clinical record each day, and we work, when I'm on the ward round, we work through that every day with every patient. And because it's a process, people know what's happening. So to think about back on what's happened over those years, this never had any investment. This is just ideas our team had and things that we could do without having to go and ask permission and ask for a lot of money. It's been never-ending plan, do, study, act, still changing all these things month by month. The importance of preparation, I used to just turn up on a ward round and go and see the first patient, but getting into your mind the background of the patients, the importance of this process. There is a process to a ward round review, a process to reviewing progress. Very difficult to measure the benefits. I'd say my conclusion for my team, which is acute medicine, is the minimum team for a patient review is the patient, the nurse, the doctor, and the pharmacist. On that basis, I've probably done about 10 team ward rounds with the proper team in Oban Hospital in 3.5 years, because we don't have a pharmacist on the ward round. All the consequence of that, medication errors, delayed discharge because we can't get the meds right and things. So I've always been playing five-a-side football with 4 members of the team. So it's not surprising we don't win. The process has actually released time to be more human and thorough. So I think our ward rounds, there's more calmness and there's more humor on them. And I think those are 2 really important measures, calmness and humor. It's very difficult to persuade other people to do this. And Nick knows that all this work has revealed to me the massive inefficiency of inpatient care, possibly matched only by the inefficiency of outpatient care in the NHS, and got me off into lean thinking and lean processes. Some of the things we did to improve efficiency, I designed a particular ward round trolley, which makes it easier to find the notes. I strong believe a laptop in the hand, not a laptop on wheels. You can pass it around to different team members, show it to the patients. Before COVID, we had a nice little stool that the consulting doctor used to sit on at the same level as the patient. We called it the chair of medicine. Certainly believe in computerized problem lists so that you know what you're dealing with each day with the patient. Probably should have smaller checklists. Continue to be interested in teaching and training. I think the reverse role rounds where the junior doctors do the rounds, I've learned so much from that, giving them structured feedback on their performance. The importance of perseverance. It feels like years and years and years, and sometimes I think we haven't achieved anything, but then sessions like you're running, Nick, and ECIST are supporting, I think shows what can happen. The importance of getting away from safari ward rounds to ward-based teams. That took 10 years at Worthing Hospital, 3 attempts until we got to ward-based teams. That reflects the perseverance. So going back, what I really hope that you would take away again is this: the practice of medicine is a human relationship. Find something that you know personal and human about the other person, the person you're working with. For me, it's usually what the person's occupation was or what their current interests are. Saw a patient last week who's over 80, going off to the market livestock sales in Oban next week to buy some cattle to take back to the island. So I can remember the patients on those sort of bases. Another consultant uses people's favorite music, but something just between yourselves to flavor and spice the work that you're doing. So we're not just continually following targets, and it's a bland, unedifying practice. And I think that's what's driven me through all of this. So know the person before making the person into a patient. This was a talk I was doing on end-of-life care last week, but such a nice picture of a patient looking relaxed, confident and happy, but ill in bed. And if we can know the person, connect with them and give them the high quality care that they deserve, then we're bound to get good outcomes. So just going back to the ordinary importance of ward rounds, it's ordinary that none of us check our tyres. We just jump into our car in the morning and we think the tyres are going to be okay, but if the tyres are bald, it's ordinary and wrong. So a lot of our work on ward rounds is ordinary, it's wrong, it's dangerous, and we shouldn't make it acceptable. So hopefully you can maintain the quality and safety of your patients on your ward rounds. You don't need a lot of resources, you just need some ideas and some determination and a strong team to work with. Thank you.
Thank you, Gordon. Once again, you know, absolutely fascinating. Well, it's been nearly 3/4 of an hour and it's absolutely flown by. So thank you very much for that. I do think, you know, you've centered this around ward rounds, but for me, as you just reflected on there about the flavors of healthcare and that healthcare patient experience, you know, it can apply anywhere, can't it? It's through the emergency front door, it's, as you say, through outpatients, it's primary care, it's adding that context. And I think it's a beautiful analogy that you've used there around, you know, adding some spice and flavor to what sometimes is just a bland, ordinary transactional process that we see. So a few questions in the chat box. I'll run through those first, and then we'll pick up any from the room. Anybody else has got any? So I'm going to come on to Liz Lees-Doyce first, because I know this is going to spark off a bit of a conversation. So Liz has put over 34 years as a registered nurse, I've seen the disappearance of the nurse from ward rounds. What are your thoughts on the impact of nurses not being on ward rounds?
Well, I always thought it was terrible that the nurse wasn't there. I mean, it sounds as if possibly qualified around the same time as me, when there was always a nurse on the ward round. It's usually a sister, maybe a student nurse. And I think what's going on in the interaction between the patients and the ward round team is very complex and nuanced and subtle. And also, you never know where the conversation is going to go and when there's going to be some surprising question. And if we do that review without the nurse and then we go back and say, oh yeah, Mrs. Smith's DNA CPR, none of the subtlety, none of the understanding has been gained by the nursing staff, and they haven't been able to contribute anything either. So I think my analogy for how nurses and doctors should work together is as close as a navigator and a driver in a rally car. You know, it's that intimate, the relationship needs to be on behalf of the patients. And to think we can substitute it by morning huddles and debriefs at the end of ward rounds, yeah, that's better than not doing them. But really the thing is to have the nurse there. And when I left Worthing Hospital, I was getting a nurse at the bedside, 1 patient in 5. And that was counting the nurse walking past and saying, good morning, Dr. Caldwell, without anything about the patient. And such a change to come to open, where we get told off if we go and see a patient without the nurse. And so the contribution from the nurses to, you know, our understanding of what's wrong, unexpected events, results of the monitoring, and, you know, even simple thing. You know, I think I often say I can bring a ward round to a halt by asking for the blood glucose level, the weight, the potassium, and the ECG. But if we got the nurses with us, then at least getting the weight and the blood glucose and things will be much quicker. So, you know, I think part of the reason I set off on all of this was just to get people to acknowledge that doctors and nurses should be working together with the patient at the bedside during the daily review. And I was very pleased when we had the first Royal College of Physicians and Royal College of Nursing recommendations on best practice for ward rounds, that it said the doctor and the nurse should be there together with the patient on the ward round.
Thanks, Gordon. Liz, is that okay? Anything you want to come back on?
Thank you very much. That's great. I was just interested. I'm in a new organisation and I'm keen to take something forward. So using your words for that will help a little, and obviously using the guidance. But yeah, great that I'm not out on my own, and the thoughts that we need to be there. Thank you very much.
Thanks, Liz. So on the same kind of subject, really, I'm going to bring Liam Chadwick in. Liam, do you want to ask your question? Are you on the call still? Do you want to ask your question of Gordon?
Yeah, hi guys. Gordon, I'm wondering, now that you have, your nurses at the bedside up in Oban, what are you doing to sort of spread the cognitive load amongst the care team, so it's not all on you as the doctor to remember every single detail for the patients?
Yeah, well, I think I've thanks, Liam, and it's wonderful to have you on the call, and greatly admire the work that you do on cyber rounds over in Atlanta. It's fantastic, which is where you take the team of healthcare professionals to the bedside on your sort of multidisciplinary rounds. I mean, I think I've been working all my career, Liam, to without knowing it, to remove the cognitive load from my head. So that's stuff which I said inside my head. Well, if I've got a printed list of the patient's problems, which I can see on the laptop in my hand, I only need to glance down to remember that they've got diabetes, rather than having to carry it in my head. And of course, well, the other thing I think is to clearly allocate roles to people. So on that ward round team formation thing, I think it said that the registrar's job that day was to look at the meds lists. So every patient, the registrar was looking at the meds list, and that was their job. So I didn't need to worry too much about the meds, because the registrar was processing the meds list in relation to diagnoses and comorbidities. So I think it's vital that, and it's something that's not recognised generally in medicine, is that what we've got to do is empty our minds of everything apart from the stuff we've got to think about and make a decision on. So the more you can exteriorize everything, the better. So you can then be free to think. So I realise now, having read the book The Organized Mind, that's really what I've been trying to do, is exteriorize everything, so that my RAM's left to deal with the important stuff.
Exactly. Great. Thanks, Gordon.
Thanks, Liam. Thanks, Gordon. Just a question from Steve Barden. And if you're still on the call, Steve, I'm probably going to leave you to ask this question, because you're probably better coming from you than me.
Hiya, Gordon. It's very thought-provoking, and I love your presentation. What concerns me in today's NHS is the resources required in order to do what your style does. And certainly on a very fast-paced acute medical unit, it's all about time and pace and pace and pace, and actually if we had the therapist and the nurse at the bedside, then there's a lot of patients not getting the care that they need at that time. And although very good for education and continuity of care, perhaps, we've had to, in a way, gone to the post-ward round huddle as a way of disseminating and sharing the information that we have. And that then makes me think that the ward round maybe isn't that important as a concept on its own, in terms of the whole day is the ward round in the way that the patient should be reviewed at the time that the patient needs to be reviewed by those that need to review the patient. And just your thoughts on that, really, and how we can kind of amalgamate all that together.
I mean, I certainly agree on an acute medical unit that the concept of a ward round may not be so useful, and that's why on that clinical care cycle I was saying it's a review of progress, and which on the acute medical unit you may not be doing in what was recognised as a ward round. There's also the bit about the fact that something can't be done doesn't mean that it should be acceptable. So I think our staffing levels are poor, and we shouldn't just accept that, and we should be saying, yes, there should be the patient's nurse present with the doctor during that patient review. On the acute medical unit, the person's very unwell. And then you can produce some simple statistics to prove the point that we haven't got the nurse there, for example, and that can help to argue for extra resources. But I think it's also, what I found was that when I was doing the post-take ward rounds on the emergency floor in Worthing and keeping a very close watch on the time it took, and that by having a process, actually it didn't take any longer than it did before, but I was achieving a whole lot more in quality, safety, teaching, training, everything, just by following the process. And I think, I trained, I think, something like 400 doctors in the process of clinical review. Now, that most of them wouldn't use the checklist, but they actually would go and look, and is there a canula? Can we take the catheter out before the guy trips up on it and fractures the hip and things? So I'm not saying that my checklist is vital. You might just say on your acute medical unit, if you're really, really busy, the one thing you're going to do is look at the drug chart and see if there's an antibiotic prescribed, and the other thing you're going to do is talk to the nurse after you've seen the patient. Just two things. That might be enough to increase the quality and the safety, and to put in some ideas of having the standard process.
Thanks, Gordon. Thanks for the question, Steve. I love those kind of challenging questions around, do we always have to do it this way? And I think it is back to what Gordon said about, do we set the standard and then aim towards it and see how close we can get, or do we cut our cloth according to what we have? And it's a balanced approach. Andrew Rochford, you got your hand up.
Yeah, thanks everyone, and I hope you can hear me. Apologies, I'm mobile at the moment and about to go under a tunnel, so I may get cut out. Gordon, thank you for sharing your sort of wisdom and passion for ward rounds. It's great. And I just wondered what your feelings are about moving more towards competency-based working rather than traditional professional silo working.
Well, working up in the far out back of west of Scotland, I think we're well used to the idea that you need people who can do stuff, and they need to be good at doing the stuff they do. My background's diabetes, and that was the area of medicine perhaps where we first started relying on specialist nurses much more than, and the nurses were very quickly taking over jobs that previously had been considered to be the doctors. So no, I'm not precious about who it is and what their title is, provided the person's got the appropriate expertise and skills for doing the part of the work that's allocated to them. And if we've got a team of people working together on behalf of the patient, we can cover all bases, then that's great.
Great, thank you, Con.
Thanks for the question, Andrew. Yeah, I think it reminds me of a comment that I think my colleague Richard Brownhill said to me last week about, if you look at the work and then design the workforce around the work, rather than maybe a more traditional, you set the rota, you set the off duty or whatever, and then hope it matches the work coming through the door, and breaking a few boundaries around that. So the last couple of questions from Pete Gordon, who was unfortunately he's had to drop off the call, but he's left a few questions for you, Gordon.
Oh, right.
One of them would be, what if you could wave a magic wand today, what non-value added activities would you get rid of to release more time to care?
I think you know the answer to that. I'd just put all the nursing documentation into the shredder and start again.
Yeah.
I mean, seriously, the nursing documentation has gone way out of control. I held up the ward round for a considerable length of time last week, wanting to know the weekly weights of a person admitted with cardiac failure and edema. And it must have taken 5 minutes just to find the first weight, and then to find it hadn't been weighed again, because the documentation is too voluminous. We used to rely on nurses' professionalism. Somebody would come in with cardiac failure, fluid overloaded. The nurse would know that you had to measure the weight each day, and the blood pressure and the pulse and the oxygen levels. You didn't need 60 pages of documentation to tell them to do it and to work through the process. And they'd also known the person was a falls risk, pressure risk, delayed discharge risk. They know that within half a minute. Why do we then make nurses spend 45 minutes, 60 minutes writing up information which we then can't find? So going back to, when your back's against the wall, what information do you need? Can you see it? Can you get it quickly and assimilate it and understand it? Not have you gone to some crazy idea that going through 40 pages of documentation is going to give you something more than a professional nurse's expert opinion.
Yeah, I thought I saw that one coming, to be honest. But if anybody who hasn't seen the photo of Gordon lying on the floor surrounded by nursing documentation, just scroll through his Twitter feed.
Oh, it's on my pinned tweet now, I think, at the moment.
Okay, it's pinned tweet. Just look at Gordon's pinned tweet and you'll see, I mean, Gordon's not a small man, and the amount of nursing documentation he's surrounded by. So that's been great. Gordon, I just thank you for your time again. I know you're incredibly busy up in Oban, so I think we all really appreciate your time spending an hour with us this afternoon, and all the other work you're doing with us on Wardrones in particular. But I think the thing for me to take away is that yes, the conversation here was centered around Wardrones, but how much of this thinking can we take away and apply in different areas? That's it for us from today. We've got our next session from ECIST is something slightly different but similar. It's to do with it's our Modern Wardrones Collaborative, but it's one of our clinical learning events, and we hear from Natalie King from SASH, who will be talking about education and training, and as Gordon mentioned before, some of the great work she's done around simulation in that organisation. So if you get a chance, the link is in the chat room. Come and join us. You be for an hour, lots of opportunities to hear from Natalie and others. But for now, thank you very much all for coming. We'll share the recording, and Gordon, if you're okay for us to share the slides, we'll send those round as well to everybody. Thank you very much, everybody. Have a good afternoon. Bye.
Bye now. Bye.